We're going to see the effect of positive pressure ventilation in cardiogenic pulmonary edema. So it's a patient with congestive heart failure that now has edema in the lungs. Alright, so the positive pressure ventilation, usually we set it to 5 to 20 centimeters of water via face mask. And first, we are increasing the pressure, the alveolar pressure, because this is the trachea. Here is some bronchi ramifications and all the ramifications until a alveoli. So we are putting air here, and all this air goes through this alveoli, and so it's inflating the alveoli, but is increasing the pressure of the alveoli. And together with the alveoli is the pleura. Here is the visceral pleura, here is the parietal pleura, and here, because we are increasing the pressure of the alveoli, and the alveoli is adjacent, is like touching to the visceral pleura. Now also the visceral pleura is like expanding and is like getting together with the parietal pleura, and so the intrapleural pressure is increasing. So because the intrapleural pressure is increasing, there is increase in the intrathoracic pressure. And now for the vessels, remember that for each vessel or airway or whatever, we have the pressure that is inside the vessel and the pressure that is outside. For example, the intrathoracic pressure. This is the intrathoracic pressure, and this is the pressure inside the vessel. The transmural pressure is equal to the pressure that is inside, minus the intrathoracic pressure. So because we increase this pressure, and this is now less negative, before the positive pressure ventilation, this is a negative number. Here always the intrapleural pressure is negative. So this is always negative, and so when we do this pressure that is inside minus something negative, this is a positive number. When we increase the intrapleural pressure, we are making it less negative, and so this number becomes less positive because we are subtracting a less negative number. So this would be a less positive number, and so because the intrathoracic pressure is increasing, the transmural pressure is decreasing. So in the vessels, for example, in the vena cava, or in the cava veins, the transmural pressure is decreasing, and so the cava veins collapses, and this decreases the preload to the right ventricle. Also, the transmural pressure of the pulmonary artery is decreasing, and this also collapses the pulmonary artery, but in this case is increasing the afterload of the right ventricle. And all this leads to decrease in left ventricle preload. Now, if the patient has cardiogenic pulmonary edema, the problems is, for example, in the filling of the heart, in the left heart, and so the heart cannot pump blood because it is overloaded, and so if we decrease the preload, the heart pumping will improve. So this will lead to improving in the stroke volume and in the filling of the left ventricle. Also, in the aorta is also collapsing, and so there is an increase in the increased resistance in the aorta. and this increased collapsing of the aorta, or almost collapsing, leads to a baroreceptor reflex that decreases the pressure, the mean arterial pressure, and this decrease in mean arterial pressure decreases the left ventricular afterload. And also there is decreasing in the left ventricular afterload due to the transmural pressure, because if the patient has the cardiogenic pulmonary edema because it's in, let's say, respiratory distress, the patient is doing a increased effort in inspiration, so is doing a profound inspiration, and so the intrapleural pressure is more negative. This is in the cardiogenic pulmonary edema, but because now the transmural pressure is less negative, the left ventricle needs to contract against a less transmural pressure, and so is better for the heart, less work, and so the left ventricular afterload also would be decreased, and all this leads to the improvement in the stroke volume and the filling of the left ventricle, and also this, because we are increasing we're decreasing the transmural pressure, and the left ventricle is getting better in the filling and in the stroke volume. This leads to increased cardiac output, and so more oxygen delivery to the tissues, and because here now the heart is less failing, because it's not failing or less, the pulmonary edema resolves, or at least decreases. And before, when we have the cardiogenic pulmonary edema, here we have the alveoli, the edema, and the capillary. So here is a problem of diffusion, because the O2 needs to diffuse through all these edema, besides the walls of the capillary and the cellular membranes, but also all this edema. So this is a diffusion problem, and so the patient has a right to left shunt. If we decrease this cardiogenic pulmonary edema, because the left ventricle is now working better, either for the filling and for the stroke volume, this pulmonary edema is decreased, because the pulmonary edema arises because the left ventricle was failing, and so the increase in hydrostatic pressure goes backward. So now that we have less pulmonary edema, there is less right to left shunt, and so besides the increase in cardiac output, or the increase in organ delivery of O2, we also have a increase in oxygenation due to the decrease in right to left shunt, and so the positive pressure ventilation is very important in the cardiogenic pulmonary edema of patients with heart failure, and the number needed to treat is 13. Is very small, because there is a lot of benefit because of the decrease in afterload of the left ventricle, and improving the stroke volume, the filling of the left ventricle, so increasing the cardiac output, the delivery of oxygen to the organs, and increasing oxygenation at reducing the right to left shunt. So the number needed to treat is 13, and this means that the positive pressure ventilation is a very important treatment for mortality and morbidity of the patients with cardiogenic pulmonary edema.